Welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. Hear about chiropractic research from the authors in plain English, not through the media nor a middleman. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I am an associate clinical professor in the Department of Kinesiology and Health at Miami University, and I'm also a chiropractor in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. Today I have the privilege of interviewing Dr. Sidney Rubinstein. But before we get to the interview, I wanted to thank all of you who have subscribed to Chiropractic Science, and I'm especially appreciative to all of you who have contributed 5-star reviews on iTunes. iTunes really helps others find out about chiropractic science. So, if you like the show, please take a second and write a review. It will support chiropractors everywhere. I'd like to share a review from someone who goes by the name Chiropractor in Sweden, who says this podcast is simply the best. Well, thank you for that review, Chiropractor in Sweden. I look forward to sharing your iTunes review in a future podcast. Please consider making a contribution to Chiropractic Science to keep these podcasts going. You can do so on our website either by making a donation or by purchasing the evidence-based patient education slides presentation at chiropracticscience.com. We are also on social media, including Facebook and Instagram, so please connect with us there. All right, on to the podcast. Well, let's get on to the interview with Dr. Sidney Rubenstein. Sidney Rubenstein is an associate professor at the VU University, Amsterdam, and adjunct research professor at Southern California University of Health Sciences. He is also a registered epidemiologist in the Netherlands. He has more than 60 publications in international peer-reviewed journals, including 3 systematic reviews in the Cochrane Library. His research focuses on effectiveness and cost-effectiveness of interventions in musculoskeletal disorders. His broader goals are to lessen the burden of neck and low back pain to society by providing high-quality scientific evidence. The projects that he currently supervises are strongly embedded in clinical practice, including the PTED trial, Warrior trial, an IPD or individual patient data meta-analysis on spinal manipulative therapy for chronic low back pain, and a large international observational study in chiropractic care in the elderly. One of his passions lies in systematic reviews and meta-analyses, as these types of overviews represent a crucial link in the practice of evidence-based healthcare. He is actively involved in conducting and supervising these reviews, including a position as on the associate editorial board of the Cochrane Back and Neck Pain Review Group. His reviews are quite diverse. One of the more recent Cochrane reviews focused on complications of trocar types for laparoscopic surgery, while another has examined the effectiveness of exercise for acute low back pain. An update of the Cochrane review of the effect of spinal manipulative therapy for chronic low back pain has been accepted by the BMJ and soon to be published. Dr. Rubinstein currently supervises 5 PhD students as well as master's students and teaches methodology of systematic reviews and meta-analyses at various levels, including the bachelor's, master's, and PhD students. One chiropractor has received his PhD under Sidney's supervision, while others are completing theirs. Well, Dr. Rubinstein, thank you so much for coming on the Chiropractic Science podcast.
Thank you. My pleasure. My pleasure.
Yeah, well, let's start out with how you became interested in becoming a chiropractor.
Okay, it's actually quite a bit of a funny story, and it's actually by chance that I considered becoming a chiropractor. I was an amateur cyclist at the time, and the team doctor was a chiropractor. At that time, I was working on my master's in exercise physiology. I knew that I wanted to go further, but wasn't sure which direction. I'd considered 2 options: working on a PhD in exercise physiology or pursuing a medical degree. Actually, there was a third option: becoming a beach bum and continue to scuba dive and cycle. But that didn't seem to be a real career option. Now, I think it's important for the listeners to understand my background. My father was a medical doctor, and my brother was completing his residency as an orthopedist. They worked exceptionally hard and long hours, and I wasn't sure actually that this was for me. At that time, I was growing increasingly interested in the idea of the body being able to heal itself. Is actually something that still fascinates me. So my chiropractic friend, the team doctor, took me to LACC to have a tour of the campus. I looked at the brochure and read the philosophy and was actually sold on the idea. I liked the idea that you could help someone using your hands. It's actually something that still, as I mentioned, still fascinates me. A surgeon does the same thing, but it's different. Surgery is invasive. What we do recognizes the inherent or innate forces of the body. Now, once I applied and got accepted, I told my father. Needless to say, he wasn't very impressed, to put it mildly. Now, when I started my education, I started questioning whether I'd made the right choice, but I met some incredible people along the way who put me on the right path and influenced my development. One of those people was Scott Haldeman, and actually the reason why I got into chiropractic research. The other is my wife. Needless to say, no, I didn't have any personal experience with chiropractic, and it was actually only at some point in time in my first year of chiropractic school that I actually received an adjustment. My wife, who is also a chiropractor and comes from a long family of chiropractors, finds this incredible. So maybe I'm naive, maybe I'm just lucky, but I think I've made some good decisions in life, and one of those was to become a chiropractor.
Yeah, that's amazing. It's fascinating that your family was in medicine and how things came about. So you mentioned Dr. Scott Haldeman and how you might have gotten involved in research. Can you tell us a little bit more about that?
Yeah, sure. That's also a bit of a funny story. I was in my second year of chiropractic school and looking for some extra pocket money. And at that time, a good friend and classmate, he came to me one day and he told me that a certain Scott Haldeman was looking for some research associates. I had absolutely no idea who he was. I'd seen his name in a book somewhere, but had no real interest in research. And after completing my master's, actually was done with research. It was a laborious process. I didn't find it interesting. I didn't find it fun, and I was done. I'd had enough. Well, obviously, my contact with Scott changed all that. At some point in time, he said to me, there are very few chiropractors with PhDs. And at that time, that certainly was the case. This is something that stuck with me in the years following. Now, shortly thereafter, after graduating from chiropractic school, my wife and I moved to the Netherlands. I didn't speak the language at the time, nor did I know the culture. It was actually a bit of a culture shock for me. But after a few years, I started to gain my footing. I was looking for a way to advance myself. Now, there were a number of things that were going on in Holland at that time, and this would be sometime in the early 90s. Two well-respected researchers and now world leaders had just received their PhDs. One was Pim Assendelft, who performed many reviews of chiropractic care and SMT. I'm not sure if any listeners will recognize his name. And another was Mars van Tulder, of course, is a world leader in low back pain. He was my mentor at the time, and he's still my mentor, as it were. And we work closely together. He's actually my boss at the university. I must say, actually, both of them, both Pim and Mars, are people who I still closely work with. Just to go back to how I got into research, I first started off, it was Mars's suggestion, with a simple descriptive study in 1999, and basically went on from there. One of the things I also want to say is that my wife, who's a chiropractor, has also had a significant and important impact on my research. We talk a lot about research in home, and she's influenced much of my thinking and the way that I approach her. Actually, without her, I dare say I wouldn't have been able to accomplish many of the things I've achieved in life. And there's just one other thing I want to say. Actually, there's one other significant person that's helped me during my development as a researcher, and that was Charlotte Leboeuf. I'm not sure if the listeners will recognize her name. Charlotte, of course, has got quite a long service in chiropractic research. She continues to publish, and she was also an important mentor for me during my research career and the beginning of my research.
Yeah, that's fascinating. I really appreciate you going through that. I think it's helpful for listeners to gain an appreciation of how one gets into research. And I had a similar experience to you after my master's degree. I thought, well, I don't want to do any more But it's funny how things seem to pull us back into the research aspect of things. So that's great. Now, I understand that you have a chiropractic practice still these days.
Yeah, that's correct. I've been actually working in practice since 1992. At the time, it was full time, 4 days a week, 5 days a week, something like that. At the moment, my time is basically split between working 2.5, actually 3 days a week in the practice, and basically 3 days a week doing research. So it's quite a hard schedule, I should say.
Yeah. Well, do you have any advice? Because I'm always looking for some. Because if anybody knows how to balance those two, that'd be helpful.
It's difficult. It's extremely difficult. I think one of the things I can say is I'm extremely efficient with my time. When I'm in the practice and I have a few minutes or whatever, I mean, I'm looking at mail. Obviously, it's not to the advantage of anyone, but I'm doing. There's only so many hours in a day and so many days in a week, and I think I'm just exceptionally effective with my time. But it's extremely difficult to balance the two. I mean, at the university, there's no other senior researcher in our department who splits clinical practice with research. It's absolutely actually a bit of an impossible task, I should say.
Yeah, no, I 100% agree. So you've published so many articles in top journals. We can't possibly talk about them all, but I know that you want to talk about the recently completed update of the Cochrane Review on the effect of spinal manipulative therapy for chronic low back pain, and that's been recently published in the BMJ, as I mentioned previously. Could we spend a little time talking about that? And then more generally, I guess, I'd love to hear your experience and your ideas about what systematic reviews and meta-analyses can tell us as well. So,
Sure. This is a minor correction. The systematic review is to be published this week or the coming week in the BMJ. So it hasn't been officially published yet, but it has been accepted, and so it'll be published soon.
Great.
Essentially, yeah, I'd like to talk about it because I think it's an exceptionally important review, and I think it has some important implications for us as chiropractors. Essentially, it's an update of the previous Cochrane Review. Now, the previous Cochrane Review on the effect of spinal manipulation for chronic low back pain was last published in 2011. We last searched for studies in 2009, so you can imagine the last 10 years have been some important and significant articles likely to influence the results and those conclusions. In the previous review, we concluded that actually SMT appears to be no better, no worse than existing therapies. I thought at the time actually was a positive conclusion. My feeling is that many of the people reading that didn't particularly appreciate that or feel it was a positive conclusion, but we can get to that. I can just take a few moments to say something about the methodology. I'm not going to talk about that too much, actually, most important results and conclusions. But essentially, in this update, we use the same methodology. So we looked at studies conducted by chiropractors, by physiotherapists, by osteopaths, by bone setters, and we looked at the effect of spinal manipulation versus non-recommended therapies, recommended therapies, sham spinal manipulation, and spinal manipulation as an adjuvant or additional therapy. Now, in the previous review, we looked at the effect of spinal manipulation versus effectiveness in ineffective therapies, whereas in this review, we looked at the effect of spinal manipulation versus recommended and non-recommended therapies. Subtle difference, but I think it has some important implications for us as chiropractors, certainly with regard to recommendations. So, in this update, we identified 21 new studies, and we included a total of 47 RCTs, represent approximately 9,000 participants. So it's approximately twice as many studies as in the previous review. Now, one of the most important conclusions of of the review is we found that SMT seems to produce similar effects as recommended therapies for pain relief and improvement in functional status. And SMT seems to produce better effects as non-recommended therapies for short-term improvement in functional status, but not pain relief. Okay, so get back to the first result, which I mentioned. SMT produces similar effects as recommended therapies for pain relief and improvement in functional status. The implications are that SMT should be considered a first-line treatment option. I mean, if recommended therapies such as exercise or prescription medication or cognitive behavioral therapy are recommended, then spinal manipulation certainly should also be included in that if the effects are similar. And this, for the listeners, that might not potentially sound so impressive, but consider that in the Lancet series, which summarized the national guidelines where it states that SMT should be considered a second treatment option. I've got it in front of me. Following exercise therapy or cognitive behavioral therapy. These results of this review suggest certainly that SMT is certainly on par with these other treatment options, and should be considered. Now, maybe in North America, that's not such an issue, but in the rest of the world, certainly in Europe, SMT is, or maybe even England, SMT is considered as a second-line option. So I think the implications of this review are going to be huge. At least I hope so. I don't know if you had a particular question about that, Dean, or wanted to throw something in.
Well, I think that's absolutely huge. This is the first time I'm hearing it, so wow. Yeah, I mean, I agree. I don't have the Lancet in front of me, but I just did recent look at that, and you're right. And in fact, I don't even think the medicine was first line, right? If I remember correctly.
Yeah, they divided it into pharmacological and non-pharmacological treatment, and certainly the movement is away from pharmacological treatment, given the fact that, for example, in the States you have this huge opioid crisis, And so the focus of many of these national guidelines, whether it be in the States or England, and there's nice guidelines, is certainly on non-pharmacological therapies. The emphasis seems to be on exercise and cognitive behavior therapy. I understand that, and the reason why is that spinal manipulation is seen as a passive therapy. The idea is that patients should be in control of their own low back pain, and I think that's great. That shouldn't exclude spinal manipulation, chiropractic care. I think chiropractors should use spinal manipulation, but it's important to inform our patients and important for them to basically treat themselves, as it were, through exercise, advice, and this kind of thing. And I think that's essentially that's an important role that we have. It's not just cracking backs or manipulating low backs. It's also educating our patients so that they don't become patients. And
absolutely. Absolutely. Yeah.
I think that's an important role that we have as chiropractors.
For sure. And, some of the more recent studies that I've sort of refreshed my mind about when they've compared chiropractic or spinal manipulation with exercise and then coupled exercise plus the manipulation, it seems like there's added benefit to incorporating both. So it seems to, it makes sense to me. And as you started out with, chiropractors are, more, I guess, holistic, for lack of a better term. And it seems like we incorporate these types of treatments anyways as part of our care. So it's a nice package.
Yeah, to use the I think it was Greg Kotchak who said at one of the meetings, this is a great time to be a chiropractor, and I think so, and I think and I'm hoping that this review will help to promote use of chiropractic care, certainly in North America and the rest of the world. I mean, in North America, chiropractic care is recognized by and large. But certainly in other parts of the world, certainly in Europe, it's a different story. I mean, chiropractors here, for example, in Holland, were so-called alternative healers. And that's actually quite remarkable, because manual therapists who perform the same type of care are recognized and chiropractors aren't. But that's another issue.
Yeah. Wow. I didn't know that.
Yeah.
Okay. Yeah. Well, I know another thing that that you wanted to hit on today was the idea of what a systematic review is, what it's capable of telling us, and perhaps how chiropractors can interpret the evidence that comes from these types of studies. And I realize that you're an expert in this, so I'm glad you're on telling us about it, because there's nobody better to be telling us this information.
Yeah. Well, systematic reviews are essentially the summary of the available information, and I think it's important that it's basically the pinnacle of our evidence base. I mean, you had mentioned earlier, of a study where the additional benefit of spinal manipulation was examined. But systematic reviews are basically a summary of all the available information, not just the positive studies, but also the negative studies. We can potentially talk about the implications of that a little bit later, because that borders or that has to do with something known as publication bias, and that's a huge issue, I think, in healthcare. It's actually something that affects all of us. But systematic reviews, I think, are actually the as I mentioned, the pinnacle of our evidence base, and I think the struggle is to identify. Actually, the struggle is cherry picking the studies which fit our paradigm, as it were. And systematic reviews are the summary of all that available information, not just those that fit our paradigm, but those that maybe go contrary to how we think or what we feel, how an intervention might work.
Gotcha.
I think it may be a long answer to your question, but
No, that's terrific. So, yeah, I mean, you mentioned that this is the systematic reviews are at the top of the pyramid. So, what I guess since you're an expert in this area, what do we do with all of that other information that's below, or toward the lower levels of the pyramid? Do we, once we have these systematic reviews, do we just get rid of that? Or and then the other question, I guess, is what about clinical practice guidelines? How do those fit in here as well? Those seem to be at the top of the pyramid too. And how do we reconcile these things?
Sure. Let's deal with your first question. It depends upon what the research question is. That evidence-based pyramid is the summary of the information, but it depends upon what your question is. Okay, so for example, if you want to know something about prognostic factors, then you'd want to conduct an observational longitudinal study. If we want to know something about diagnostic accuracy, if we want to know, for example, mammography is an effective screening tool for women with breast cancer, or we want to know about effectiveness, then you'd want to conduct a randomized controlled trial. If you want to know something about the existing data or information on a given area, or cost effectiveness, then you'd have to look at systematic reviews, economic evaluations. If you want to know the association of, say, a rare event to a given exposure, then you'd have to look at case control studies. Or if you want to describe treatment for a rare condition or something, then you'd look at case studies or case series. So it depends upon what your question is. Systematic reviews are great when it's summarizing information on effectiveness or diagnostic accuracy. But if you have another research question, you might just have to look at individual studies. Because given for a particular question, there might only be a few studies, and that's certainly not worth it to conduct a systematic review on that.
Great, yeah, that was a terrific answer and exactly what I was hoping for.
So systematic reviews answer an important question, but it depends upon what that question is.
Gotcha. And what about clinical practice guidelines as a follow-up to that? How do they fit in? Do they essentially use the meta-analyses and systematic reviews to put forth what clinicians should be doing, or
to a large extent they are. The clinical guidelines are based upon systematic reviews and meta-analyses. Just for the listeners that they understand, systematic reviews is the entire process of summarizing the data, beginning with formulating research questions, searching literature, selecting the studies, assessing the methodological quality, and combining those results. Meta-analysis is only a small part of that. It's the statistical method for combining from individual comparable studies. So that the listeners understand the difference between what a systematic review is, that's the entirety, and a meta-analysis is only that a small aspect of that. But getting back to the question, the role of systematic reviews in guidelines, systematic reviews will help to inform a guideline commission to make policy, but that policy is largely determined by who's on the committee. For example, here in Holland, spinal manipulation actually wasn't even included in the guidelines. It wasn't really even considered, and I think that has largely due to the fact that there wasn't a chiropractor involved or a manual therapist. For example, in North America, in Canada, or in the States, I mean, of course, chiropractors are quite integrated, so they're all part of this guideline procedure, and so of course, spinal manipulation is recommended. So systematic reviews inform guidelines, but they're not directly translated into policy. Yeah.
right?
It's people who are interpreting these data and making decisions.
Yeah, I was just going to say it still requires people.
It still requires people.
Yeah. Yeah. And so, well, that gets us to another thing that I know you wanted to talk about, which was publication bias and, some of the potential strengths and the weaknesses of these kinds of studies. So maybe you can talk about that a little bit.
It plays a huge role in systematic reviews, because systematic reviews are a summary of all the available information. Actually, the should be a summary of all the available information. But with publication bias, it's the positive studies, or studies with positive findings, have a greater chance of being published. So it's typically the smaller studies with negative findings that are not published. So you can imagine, if you have a summary of studies that all have positive findings, it would seem to suggest that an intervention works well. There are lots of examples in the literature where publication bias has been a huge issue. So, for example, the Mexican flu that broke out here in Holland about 10 years ago, and about 10 years ago here in Holland and UK and Australia, we spent billions of dollars in buying in something called Tamiflu. I don't know if it's what the trade name is in the States.
Yeah, it's same name here.
Okay. It turns out it doesn't work. And now you can imagine, now here in Holland or the UK and Australia, these people are not stupid. They're not going to spend billions of dollars on something that doesn't work. And I think the decision was partly based upon a Cochrane review. I mean, Cochrane reviews, they're above critique. Problem was that Cochrane review, at least sort of I understand it, the Cochrane review was based upon only a part of the evidence, and the part of evidence seemed to suggest that it worked well. Now Roche Pharmaceutical, and this is all to read on the internet. Roche Pharmaceutical had not released the studies that seemed to suggest that it didn't work.
Oh wow!
Yeah. So and I mean, pharmaceutical company is not in the business of now let me put it this way: they're not a philanthropic organization. They're
right.
They're there to make to keep their aandeelhouders. Sorry, for lack of a better word, I can't find the word in English. They're there to keep people happy. They're there to make money. And so they didn't publish the negative studies. And there's lots of other examples, things affecting us, even something today. one of the board members of the Cochrane collaboration, Peter Gotsche, he's critical of big pharma, and there was a recent Cochrane review which looks at the effect of the human papilloma HPV vaccine, and it was a Cochrane review. It was the authors were funded by industry, and they included by and large those positive studies. And there's suggestion that actually doesn't work well. It might even be dangerous. There's same questions that can be raised potentially about mammography. So publication bias is it seems like an academic issue, but it's something that affects all of us. And so when you conduct a systematic review, the idea is you try to gather all the available information, not just the positive studies, not just those studies that fit our paradigm, but also those studies with negative results. The problem is, if those studies aren't published, it's difficult to make a decision. There is a technique that we can something we can do. We construct something known as a funnel plot in order to see if potentially there's a study with negative findings, but still it's only a suggestion. Right?
Gotcha.
So that's an important implication, of conducting systematic reviews.
Absolutely. Yeah. Well, hopefully, we get letters to the editor and things of that nature that come out that we can look for as well to point some of these things out, especially for clinicians who may not be doing this, may not have ever been involved in a systematic review, but realize, hey, I'm sure there could be more to the story.
Sure.
We have to rely on our researchers too.
And something with regards to the spinal manipulation review, you can also ask yourself, okay, then I'm being exceptionally critical. I'm the researcher. It depends upon where I am and what you ask me, whether I'm researcher first or a chiropractor first. If you look at the studies that we included in the B&J publication, I mean, they're all basically initiated virtually all by clinicians. And so you can imagine, there might be some studies that are set up and designed and conducted and potentially not published because the results are contrary to what we believe, or the data is massaged to demonstrate positive findings. And there's all sorts of tricks you can do in order to come up with some positive results.
Sure.
Okay.
Yeah, absolutely.
But hey, so for example, maybe for the listeners, hey, what are some of those tricks? Well, you can measure 10 different outcomes, hey, and you report those outcomes that are statistically significant. Well, we know what the most important outcomes are. In the case of low back pain, we have a core set of outcomes: pain, functional status, recovery, quality of life, return to work, that kind of thing. Those are the outcomes you would expect to see. But, some studies, they might say, yeah, well, we found this to be statistically significant and report about that in the abstract, for example, and all the other outcomes which were measured, are not reported or reported somewhere else and given less importance. So there's all sorts of tricks that researchers can do to massage the results the way they want it. Yeah.
Right, for sure.
That's unfortunate.
So then how do we, for the chiropractor in practice, or maybe chiropractors who have some, let's say, political influence or legislative influence, how should they go about the impact of these types of studies in particular for clinical practice? in other words, what do they do with them? We have these conclusions. Do we then just say, "Hey, legislators, here's the results of the recent meta-analysis on low back pain. We'd like you to include chiropractic care into the practice of whatever."
I think we make a strong argument. I mean, for example, this update to the systematic review. I mean, we've included 47 RCTs representing more than 9,000 individuals. We know, and we know what the effects are. We have strong confidence in it, and we can predict what the effect will be in a future trial. Now that might sound a bit strange and a bit funny, hey, for those who are versed in research or whatever. I mean, when we express an effect, as it were, we have this expressed with a confidence interval, as it were. Okay? So confidence interval basically says if we were to repeat this study basically 100 times, 95% of the time, we can be pretty sure where the effect will lie. Will lie somewhere within that margin of error. Now, in prediction intervals, we can predict what the result will be in a future trial, and we've done that. So we pretty much know. I mean, I dare say we're done. We know what the effect is of spinal manipulation compared to recommended therapies. We don't have to do this anymore. I think we can make a relatively strong argument, but there's all sorts of things actually we still don't know. For example, we don't know if it's cost effective, and actually one of the most important things is we don't know who's likely to benefit from spinal manipulation for chronic low back pain. Now, I've got 25 years of experience in the field, and I still can't predict which patient's likely to benefit from spinal manipulation. Now, one of the things we've done in the last few years is a good colleague of mine. She's working on her PhD. She'll probably finish up this year. And you mentioned it, Dean, at the beginning at the introduction, and something called an individual patient data meta-analysis. It's in short, it's an IPD meta-analysis. We have the individual patient data of something like 20 randomized controlled trials. Now, in this systematic review meta-analysis, just to explain a little bit to the listeners, we take what's called the aggregate data. This is the data that's reported in the trials, and we pool that. We combine those results. Now, in individual patient data analysis, we have the actual individual patient data, which means we can construct our own models. We can correct for confounders and effect modifiers, and we can look at these kinds of things. That's actually the goal of IPD meta-analysis. And with this type of analysis, we're able to look at which patients are likely to benefit from care. The problem is even with all the something like 5,000 patients, 21 randomized controlled trials, we still weren't able to identify which patients are likely to benefit from spinal manipulation. So even with my experience and even with conducting these quite sophisticated analyses, we still don't know which patients are most likely to benefit from spinal manipulation. And very broadly, we can say those patients with acute low back pain are most likely, they'll have a favorable prognosis, whereas those with chronic low back pain, less favorable prognosis. But that's pretty much it,
Right. Yeah. There's a whole lot more to know. Absolutely. And, I just look at my own research, and it's kind of like the Wild West, looking at certain measures of function and performance. There's just really nothing out there. So it's frustrating, but exciting at the same time.
Yeah.
So, well, I really appreciate all of the great information you're giving us. One last thing, if I could just tap you for one more thing, and that is...
my pleasure.
Yeah. One of the goals of this podcast is to get more chiropractors into research. And so what I'd like to ask you is anything that you could offer, any kind of advice you could offer to those folks who might be considering a research career in chiropractic or manual therapies or whatever the case may be. What advice might you give them?
It's actually quite simple. I think you need to seek a mentor who's who can basically guide you. I mean, as I mentioned in the beginning, I met some incredible people along the path, and people who helped guide me. I met Scott Haldeman. I met Charlotte LeBouf. My wife has had an important influence on me. I've met some incredible and Mars van Tulder, he was an important mentor for me, and Pim Asendorf was an important mentor for me in beginning years. Mars is he's still my mentor, my boss, as it were, and these are people who influence the way I think, and so for anyone contemplating the research career, it's important to have someone who's knowledgeable, who has a passion, there has to be also, of course, a certain passion within the person themselves. When I started working on research, I worked 1 day a week at the university. I was paid basically a pittance. We received something like 40,000 euros for 4 years, half of which went to my research assistant, and the rest of half of that 20,000 went to me for 4 years. And I invested an enormous amount of time and my own energy into working on my PhD. I didn't know where it was going to take me, but so there's two things. The person has to be extremely motivated, and there's going to be lots of moments. I mean, if you embark upon that path, there's lots of moments where you think, I don't know why I'm doing this. I mean, there's also times when I come home from the university, I think, I'm not quite sure why I'm doing this anymore. But we all have moments of doubt and moments of failure. But it's beautiful to be able to advance knowledge, to provide information. And as I mentioned, the fact it's important to have a mentor, someone who also has a certain shares that same passion, and so that would be my advice.
For sure, and that's fantastic advice. And I tell you what, we really appreciate everything that you do. So please keep up what you're doing. I think we all, whether we're in practice or doing research, or maybe a combination of both, we do have those days, but realize that your work is highly valued. So thank you for doing what you do. And thanks for being on the podcast today. Really appreciate it.
Thank you very much. My pleasure. My pleasure.
Yes. Thank you.
Thank you.
Thanks again for listening to this episode of Chiropractic Science with Dr. Sidney Rubenstein. Well, I'm really excited that you got to hear this episode, because that paper in BMJ, British Medical Journal, dealing with chiropractic or spinal manipulation therapy and chronic low back pain is going to be a huge paper for the profession. So thanks again for listening. Take care and have a wonderful day.